keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Welcome, ladies and gentlemen. I'm Stefan Achenbach. I'm one of the associate editors of JACC Cardiovascular Imaging, and I'm here today with Dr. Trong from the Department of Radiology of the Massachusetts General Hospital. Dr. Trong has a paper coming up in one of the next issues of JACC Cardiovascular Imaging about the use of CT to investigate dyssynchrony in patients with heart failure. Dr. Trong, can you please tell us in a few sentences what your study was about?
So in our study, we report a new method to quantitatively assess left ventricular dyssynchrony using cardiac CT. What was also new about the method is that we evaluate changes in wall thickness over time instead of wall motion or volume. So as you know, there's currently no gold standard for dyssynchrony assessment, and 30% of patients who receive cardiac resynchronization therapy are considered non-responders and clinically either deteriorate or simply do not improve. So in a proof of principle study design, what we wanted to find was a cardiac CT measure that would be highly reproducible and also determine whether it would be feasible to detect and quantify dyssynchrony using CT.
So how many patients did you include in your study?
So we evaluated 38 patients, and we took 3 groups of patients who had undergone 64-slice CT for coronary artery assessments. We classified them as either heart failure wide QRS patients, heart failure narrow QRS patients, and age and gender matched normal controls.
And what did you find when you looked at these patients?
So from the short axis images of the left ventricle, we actually measured several CT-based global and segmental parameters. We looked at time to maximum wall thickness, time to maximum wall motion, and time to minimum systolic volume. What we found was that the wall thickness measure that was global had the best reproducibility, and we called this DI for dyssynchrony index. There was significant difference in DI between the 3 groups, as well as between heart failure patients and normal controls. The highest DI was seen in patients who had the heart failure wide QRS, followed by the heart failure narrow QRS patients, with the lowest DI seen in patients who were in the normal control group.
So let's speak a little bit more about this DI, this measure that you developed.
Yes.
What specifically did you look at? You divided the left ventricle into various segments, and then what was your measure? What did you actually measure?
Yes, so each of the short axis images were subdivided into 6 standardized segments. From that, we would do a standard deviation of the time to maximum wall thickness.
So you measured the time from the R peak, I think, if
Correct.
I remember correctly, to the maximum wall thickness.
Correct. And so we'd take the standard deviation per slice, and then we would average the standard deviation of all the slices to get our dyssynchrony index.
This sounds like a very complicated measurement. Can this be automated in some way?
Well, I think there's more to be done in terms of software automation, and there's lots of improvement in that area.
So your hope would be that this would be a parameter that CT can deliver to better identify patients who will profit from resynchronization. But so far, prospective studies have not been performed.
Correct. This is a proof of principle and proof of concept study, and the CT scanner that was used in this study was the 64-slice CT scanner, and the temporal resolution from that scanner was quite limited. But what's amazing about it is that despite the limited temporal resolution, we were still able to discern a significant difference between patients most likely with dyssynchrony and patients who are normal control without dyssynchrony. So with the newer temporal resolution CT scanners, the newer CT scanners with better temporal resolution, I think there's great potential for CT to be able to assess dyssynchrony.
Another issue that is frequently mentioned with CT is, of course, radiation exposure. And since you need to have images throughout the entire cardiac cycle, potentially radiation exposure might be high. There are radiation-lowering procedures available for CT, like EKG pulsing. Can these be used and you can still obtain your measurement, or do you have to give lots of radiation to the patients?
For the functional assessment of this measure, we probably would have to use the entire cardiac cycle to get the time to peak wall thickness. The radiation issue is obviously of a concern. However, these are New York Heart Functional Class 3 and 4 patients, and they're 50% 5-year mortality. They have 50% 5-year mortality. So they're a much higher risk patient, and their mortality rate is much higher. So the long-term consequences of cancer may be less of a concern.
Mm-hmm.
The advantage of CT is that you can simultaneously also get the coronary veins. And, this might be very helpful for the electrophysiologists as they're planning their lead strategy.
Absolutely. Sounds almost like a one-stop shop for heart failure by doing CT.
Yes. Unfortunately, there is no one-stop shop right now, but I think as we continue to work on the research and develop more software algorithms and the CT scanner improves in terms of its temporal resolution, it may be.
So are your electrophysiologists using this information obtained from CT right now in clinical practice, or is it still more of a research setting?
This is definitely still more of a research study, and our electrophysiologist is using coronary veins with our dual source CT scanners. However, we will be doing prospective studies to validate and correlate this metric to CRT response.
Okay, thank you very much. It will certainly be interesting to see how this develops in the future. Thanks again.
Thank you so much.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.